Okay, welcome back to this lecture on water, electrolytes and pH balance. This is getting, more complicated. Here you have the objectives, so we will review basically two electrolytes which are very important. That's sodium and potassium. There are many other electrolytes, but these two are of great importance. Sodium, you know that water follows sodium, so what happens with sodium will have a reflection on water balance, right? And then finally we will talk about acid-base balance, which is very important because the body can work only in a very, very small margin of pH, so any deviation of pH has many consequences. We will start with hyponatremia. And in hyponatremia, hypo means low and natrium is the Latin word for sodium, often written as Na+. And emia refers to blood, so hyponatremia means a lower than normal concentration of sodium in blood. Generally below 135 milliequivalents per liter. The concentration of sodium depends on both sodium and water levels in the body. You know that about 60% of our body weight comes from water, just from water, and it basically sits into fluid compartments. 1/3 is in the extra cellular fluid, meaning outside the cells, and 2/3 of it is inside the cells. The extracellular fluid includes the fluid and the blood vessels, lymphatic vessels, and also the room, the space between the cells that is called interstitial space, which is also filled with proteins and carbohydrates. Normally, the two compartments have the same osmolarity, which is the total solute concentration, and that lets water move freely between the two spaces, but the exact composition of the solids differs quite a bit. The most common cation in the extracellular compartment is sodium, while in the intracellular compartment is potassium and magnesium. The most common anion in the extracellular compartment is chloride. You see it there in the drawing that is like a cell. It represents a cell. And in the intracellular compartment is phosphate and negatively charged proteins. Of all these, sodium is the ion that moves back and forth across membranes. So subtle changes in sodium concentration till the osmolarity balancing in one direction or another, and that moves water as well. This is why we say that water follows potassium. That being said, hyponatremia or low concentration of sodium in the extracellular fluid, and therefore the blood, may be caused by either losing more sodium than water or gaining more water than sodium. Broadly speaking, hyponatremia can be divided into three categories based on water volume status. The first is hypervolemic hyponatremia, where there's a huge increase in total body water and only a small increase in total body sodium. So, in this case, you're gaining more water than you are sodium. Typically, this is seen in conditions like congestive heart failure, cirrhosis, or nephrotic syndrome that we will see later during the course, where a ton of fluid leaks out of the blood vessels into the interstitial space and it causes edema, especially in the ankles. Even though there's more water overall, there's a decrease in the effective circulation volume, what is the amount of blood flowing in the body. This stimulates the release of antidiuretic hormone, which retains pure water, leading to an increase in total water. And it also stimulates the release of aldosterone, which retains a little sodium. We will see aldosterone with the kidney. You are supposed to know it from human structure and function too. But remember that since water follows sodium, the body ends up retaining even more water as well. So ultimately, you can see that there is a large increase in water, but only a small increase in sodium, and this leads to hyponatremia. The second category is hypovolemic hyponatremia, where there's a small decrease in total body water and a large decrease in total body sodium. In other words, you are losing more sodium than you are water. Alright, so this can happen in conditions like diarrhea or vomiting, where the cells lining the gastrointestinal tract actually pump sodium ions into the digestive juices, but then those ions don't get reabsorbed because the undigested food in the digestive juices is tossed from the body. It can also happen in response to using certain medications like diuretics. Diuretics, they are for you to excrete more water, more liquid, right? So with these medications, sodium ions are pumped into the renal tubule and then lost in the urine. Another more extreme condition is cerebral salt wasting, which is an increase in intracranial pressure, like in meningitis, that disrupts the normal sympathetic nervous system stimulation of the kidneys, and this leads to an enormous loss of sodium. Then a third category is euvolemic hyponatremia, also known as normal volume hypovolemia. And this is where there's a normal body sodium but an increase in total body water. And the reason that is given this name is that you don't have water pouring into the interstitial space, and therefore there's no edema and so no clinical signs of hypovolemia. Euvolemic hyponatremia can be split into cases with dilute urine and concentrated urine. Cases that cause diluted urine include adrenal insufficiency and drinking too much water, what we call polydipsia, or drinking too much beer, that is called potomania. Basically here the body has a lot of water and the kidneys are trying to get rid of it as best as they can. The main condition that causes concentrated urine, on the other hand, is syndrome of inappropriate antidiuretic hormone secretion, that you can say just SIADH. This is where inappropriate presence of antidiuretic hormone causes water retention, which ends up meaning the urine gets more concentrated. Now there's one final type of hyponatremia that it's sometimes called a false hyponatremia or pseudo hyponatremia. This is where the body water and sodium levels are normal, but there's an excess amount of lipids like hypertriglyceridemia, or there is an excess of proteins like in multiple myeloma. High levels of lipids and proteins can affect the laboratory instruments that measure the sodium concentration and make the instruments say that the sodium concentration is too low, which is at the end is false. Hyponatremia can cause symptoms like nausea, vomiting, and muscle cramps. In severe hyponatremia, which is when the sodium concentration falls below 120 milliequivalents per liter, there can be cerebral edema, which can cause confusion, coma, and even death. The cerebral edema results shifting from the extracellular compartment to the intracellular compartment, causing the cells in the central nervous system to swell up and get damaged or even die, because they break. If they get too much water inside. They can also cause increased intracranial pressure, which can squash the blood vessels of the brain, and this will cause ischemia as well as possible brain herniation, which can damage the respiratory centers, which are, in the brainstem, and cause respiratory failure and death, of course. Hyponatremia is usually diagnosed by looking at physical exam findings as well as labs from the urine and the blood. For example, a low serum osmolality suggests true hyponatremia versus the false one, the pseudo hyponatremia, which shows a normal serum osmolality. In addition, signs of edema suggest hypervolemic hyponatremia, while signs of dehydration suggest hypovolemic hyponatremia. Also, urine osmolality can help differentiate between the two types of euvolemic hyponatremia. If the urine osmolality is really concentrated, greater than 100 milliosmoles per kilogram, then the problem might be SIADH. On the other hand, if urine osmolality is dilute, that is less than 100 milliosmoles per kilogram, then the problem might be due to taking too much liquid. That was called polydipsia. The urinary sodium concentration could be also helpful, with greater than 20 to 40 milliequivalents per liter, suggesting the syndrome of inappropriate ADH and cerebral salt wasting. And less than 20 milliequivalents per liter will suggest hypovolemia. Treatment of hyponatremia depends on the underlying cause, of course. So if you address that, you don't have the problem, or you solve the problem. So in patients with the syndrome of inappropriate ADH, fluid restrictions generally is the first line of therapy. On the other hand, if patients are hypovolemic, giving more fluid can be helpful. Generally speaking, for severe hyponatremia, it is important to give hypertonic saline, but you have to provide that really careful, slowly, to avoid complications like cerebral pontine myelinolysis, which is the loss of myelin in the pons, which is a structure in the brain, you already know, and this is due to rapid shifts in sodium and water. Okay, this is all. It seems quite complicated. This is why it's in the form of maps, but you have to read it with, carefully and calmly, and you'll get it. All right. So now let's move to hypernatremia.